I think from a chemotherapy versus ADC sequencing question, we now have ample evidence that the ADC typically should either precede chemotherapy entirely, or after 1 to 2 lines of chemotherapy, it's reasonable to move to an ADC. I think in the setting of HER2 low or HER2 ultra low disease, or breast cancer specifically, we have the option of using trastuzumab deruxtecan, and we've now seen the DESTINY-Breast 04 and the DESTINY-Breast 06 trials, which have shown the superiority of T-DXd over chemotherapy for HER2 low, and DB06 showing activity for HER2 ultra low disease. The additional knowledge we gained from DESTINY-Breast 06 was this trial tested T-DXd in a more frontline setting. So these were patients who had received endocrine therapy and then went on to the trial before receiving chemotherapy in the endocrine resistance setting, and we saw the superiority of T-DXd over standard chemotherapy there. So I think from a sequencing standpoint, when I'm thinking about a patient with hormone receptor positive metastatic breast cancer, I'm thinking about whether or not they're HER2 low or ultra low, and if they are, reaching for T-DXd after we've exhausted endocrine therapy. If they are not HER2 low or ultra low, in other words, if they're HER2 null, so no membrane staining at all, then I will likely use a line of chemotherapy like Xeloda and then move on to datopotamab deruxtecan. Now the question is, if they're HER2 low and ultra low, when can I use datopotamab deruxtecan? And I think this is where we have observational data sets which demonstrate that when you're sequencing 2 ADCs, whichever ADC you use as your subsequent ADC is likely to have less activity than the first ADC that you used. Now, whether that's because you've advanced in your lines of therapies, or whether that's because the first ADC is truly engendering some kind of resistance to the subsequent ADCs, I don't think we know the answer to that. I do suspect it's because of the natural history of the disease and moving to the next line of therapy. But in the hormone receptor setting, there's some evidence to suggest that sandwiching a chemotherapy in between the ADCs might increase the efficacy of the subsequent ADC. So I tend to do that if I use T-DXd first, then maybe a line of Xeloda next, and then go to Dato-DXd. But in the triple negative setting, where we have limited treatment options, I have sequenced ADCs back to back. And typically we'll use a TROP2-directed ADC in the first line, like Dato-DXd, and then if they are HER2 low, then I will consider using T-DXd as a subsequent line of therapy.